All right, so it turns out that when I move my camera so that the screen doesn't show up, turns on the image change and all that sort of thing. So let's get into it. Welcome everybody into, oh man, we're just having all kinds of quirks today. It's a weird day in the neighborhood to answer James's question right off the bat. There we go. We'll try that, see how that goes. Who knows what's going on here. So, change one thing real quick here. There we go. That's a little bit better. See how that looks. So my name is Mike Hess. I am Let's try that again. My name is Mike Hess. I am a COPD navigator and advocate and educator. And contrary to appearances at the moment, I really do know what I'm doing. Welcome to COPD Navigator House Call. This is, for those of you who may be new around here, I run a Facebook group called COPD Navigator that is filled with people living with COPD, caregivers, clinicians of many different stripes. We've got a great group in there, and we get together to talk about COPD stuff. We do a live show about every 2 weeks usually. During this novel coronavirus crisis, we are doing something every day here at 4 p.m. Eastern Time. So we got started a couple minutes late today. Also starting a thing on Twitter. So we got the Twitter feed over there. If anybody happens to be a tweet fiend or Twitterer or whatever we want to call that, that's going on there. We do, like I said, this is a great time to get your questions in. Figure out what we can do with answering your COPD related questions, your respiratory related questions. Again, this is kind of a free-for-all sort of thing. I do have one interesting topic that I want to get into today. Some information came out via Twitter. Well, I think I first saw it via Twitter. Coming out of Europe, some very well-respected pulmonology groups over there, and I want to get into that. First off, of course, I want to say hello. Say hello to James. As mentioned, from Oregon. Things in Michigan are a little bit strange, but we're making do here. We had a little bit of technical quirks right at the beginning, more physical quirks, I suppose. Just things weren't quite lined up correctly, and tried to do a little bit of pre-work this morning, and it just didn't quite work out the way I had hoped. So it is what it is. Also saying hello to John. Thank you for not paying us close enough attention. 6-foot hugs to you as well. I got one other thing fired up here, and then we're going to get into our initial topic of the day. Again, if there's some stuff you're interested in chatting about, please be sure to go ahead and drop that in a comment wherever you happen to be looking at it. So, I'm going to get out my handy dandy other laptop here, and hopefully all the stuff that I had prepared saved in an appropriate place. The article that I really want to get into today talks about, yep, I'm right here, computer. There we go. Hello, computer. Right here. There we go. The key to the article, the thesis statement, I suppose, if you will, is that a lot of folks with COPD are not currently, or I should say, I should go the other way here. COPD is essentially underrepresented in what we would expect for populations with the COVID-19, the disease that is brought on by this novel coronavirus. And so there's a lot of question about why that might be. I want to go back and look. Let's see. So the original article asks, that's not the original article here. Where we got here? Which way did I go with it? That's not it. That's not it. I thought I saved that one real quick, but I'm going to pull it up again real quick because I want to go through the actual article and let's see. I'm going to go through the actual article, talk about the data a little bit, and then see what else we have here. So let's look at the... I thought I had all this stuff good to go, but apparently I did not. So we're going to... All right, well, I guess I won't do it from there because that's just being a pain in the old keister. So we're going to pull up another window here and we're going to check out COPD COVID-19 under report. And now I can't find it. Come on. Best laid plans, folks. Best laid plans. All right, well, this is a great opportunity for, again, you guys to get your questions in while I am continuing to fumble around here. Like I said, it's been kind of a weird day. There's a lot of weird juju going around right now. In a lot of different circles. You know, we've got this whole isolation quarantine thing going on pretty much everywhere these days. I just saw Broadway shows are anticipated to be closed until June now, into June. So that's not great. That doesn't bode well for some of the other issues. Here we go. Some of the other issues that are popping up, or some of the other, you know, as Bonnie's saying here, still bad in New Jersey, not going up as fast as it was, fingers crossed. So we've got kind of a similar situation here in Michigan. We get an update about 3 o'clock from our State Department of Health and Human Services. It's slowed a little bit as far as the last day or two. Whether that trend is going to continue, and we're going to actually see kind of the top out of the curve, that remains to be seen, because we've had, you know, when you look at discrete chunks of data day to day, it's not really a line. You know, you look at 3 days, 4 days. A lot of times you have like a rolling 5-day average, let's say. That's really where your trend line comes into play. So we're seeing some stuff coming in here. And whether it pops up or not, we'll have to see here. Why is this one asking me for a membership now? I was reading this just this morning. And I know I actually found the actual article was published in a journal. So here we go. Well, by David Halpin, COPD COVID-19. Let's try that. So for those of you who may not know, Dr. Halpin is a remarkable pulmonologist out of, I believe he's in England, and he's been on the forefront of a lot of COPD research lately. Here we go. So this is the article here. Finally, at long last. The introductory paragraph says, coronavirus disease 2019, COVID-19, which is caused by this SARS-CoV-2 virus, which we commonly call the coronavirus, but is actually one of about half dozen. I think there are 7 now known different coronaviruses, which I thought there were more, but that was what the article I was reading earlier today said. Is, you know, of course, we see that we're having a lot of lung issues. We're seeing a lot of low oxygen states, all that sort of thing. previous epidemics of novel coronavirus diseases such as SARS, that was well in the early 2000s, Middle Eastern Respiratory Syndrome, which I believe was around 2012-ish, still kicks around here and there, were associated with similar clinical features and outcomes to this issue. One might anticipate that patients with chronic respiratory diseases, particularly COPD and asthma, would be at increased risk of SARS-CoV-2 infection and more severe presentations of COVID-19. However, it is striking that both diseases appear to be underrepresented in the comorbidities reported for patients with COVID-19. So if you go into the hospital and get diagnosed with this COVID thing, you aren't also, the comorbid conditions are things like asthma, COPD, diabetes, things that you have in addition to. So that's where, actually, now that I'm thinking about it, I'm going to drop a copy of the link here into the feed and into the watch party. So we would expect it to be probably at least as much as the normal population rate, which we figure somewhere between 10 to 15% in the U.S. probably, or even a little bit higher, because we anticipate that somebody with one of these conditions would be more susceptible to the disease. But that has not been the case. And I do see a comment I'm going to get to in just a couple of minutes, but what we're seeing here, let's see. So we're going to look at a couple of different reasons why that might be. So the first potential thing that they throw out there, and again, I did wash my hands right before I came down here. It is possible that, in contrast, what they did was they compared it to diabetes, because they're seeing diabetes at the rate that one would expect, but not asthma and COPD. So they're saying that in contrast to diabetes, there's substantial underdiagnosis of poor recognition of chronic respiratory disease in patients with COVID-19, particularly in China. Although then they turn around in the next sentence and say this seems unlikely because the data wasn't really supporting that conclusion. But it is possible. It's possible that the group of people, because we all know that we don't do a fantastic job with diagnosing COPD, we don't always do a great job with diagnosing asthma, there might be some underdiagnosis of these conditions. Oh, there's a glimpse behind the curtain on Twitter. Don't like that. Anyway, so we're seeing if that might be a potential issue. A second possibility is that having a chronic respiratory disease in and of itself protects against COVID-19, perhaps because of a different kind of immune response elicited by the disease itself. So maybe your immune system being constantly triggered by having a chronic condition, maybe that makes you more able to fight off COVID or the coronavirus. However, again, in the next sentence, they go on to say this theory is not supported by the finding that among those with COVID-19 who have COPD as a comorbidity, mortality is increased, which is what we would expect. So if you end up, while the numbers are saying not as many people as we would expect get COVID, those that do get more severe and are more prevalent to have mortality. A third possibility is that therapies used by patients with chronic respiratory diseases can reduce the risk of infection or developing symptoms leading to diagnosis. And this is where it starts getting kind of interesting. It is important to note that at most only about half the patients with COPD in China take treatments that are standard in Europe and North America. But so we don't necessarily see a lot of the bronchodilators, but up to 75% of people in China with asthma use inhaled corticosteroids, which is appropriate. Furthermore, on lab models, inhaled corticosteroids alone or in combination with bronchodilators have been shown to suppress coronavirus replication and cytokine production. So a couple of things to unpack there. We are seeing that, we've kind of taught, particularly in COPD, that the use of inhaled corticosteroids can sometimes be bad because it can lead to pneumonia. It can give those kind of issues. In asthma, it's still pretty much a mainstay of care. So trying to wake up my other computer here again. So what we're seeing is while the folks in China don't necessarily use as much in the way of, there we go, because we got some other things here. They don't necessarily use as much in the way of bronchodilators. They do still use a lot of inhaled steroids for asthma in particular. And so then I was able to find this other study that was published actually back in February in a journal called Respiratory Investigation, which I'm not terribly familiar with, but they did find that glycopyrronium, which is in it's in Bevespi, it's in a couple of different things these days. Ultibron, it's in the nebulizer one, the not Upelri, but the other Lonhala. It's in a couple of different things. So glycopyrronium and formoterol, which is a fairly common bronchodilator in things like Symbicort, and also budesonide, which is one of the most common inhaled corticosteroids, does prohibit or inhibit replication of another kind of coronavirus. Now, this study didn't look exactly at this new one because it's brand new. We haven't really been able to do that lab testing yet. But there is some thought that these combinations, whether work in some kind of combination with each other to various degrees, or let's see, independently and all together, they did seem to stop the virus from replicating through some chemical disruption. So it's possible those folks with COPD who are on these medications on a regular basis are seeing a benefit from that because they're getting that virus killed right off the bat, and maybe even to a point where even if they do feel a little bit sick, maybe it's more along the lines of maybe it feels like an exacerbation or something like that. It's not quite as severe, so they don't go in for treatment. Or it's actually not as severe because there's not as much of a viral load. Really hard to tell. We also, let's see, they also say inhaled corticosteroids alone. Yeah, so we did that. Low quality evidence also exists from a case series in Japan with a different kind of inhaled steroid, but they didn't use a control group. So they don't know if it's actually, maybe these people would have gotten better, maybe not. It's hard to say. But since it's combined with this other study that says steroids might be good against coronaviruses, might be helpful. So the conclusion to this was that the potential benefits or harm of inhaled corticosteroids are unclear at present, and no changes to the treatment and management of chronic respiratory conditions should be considered at this stage. So that's an important thing to point out, because there have been a lot of people saying, well, 1 minute steroids are bad, 1 minute steroids are good. Are we supposed to continue on the regular stuff? Continue on your regular maintenance as indicated. There are a couple of other things I wanted to consider that I don't know that these necessarily, this study actually addresses. And one of them came actually from longtime navigator Bonnie this morning, who mentioned wondering if weaker immune system has something to do with this, as many experts are saying a very strong immune response might be making this worse. And that's a very good thing to point out. The whole idea of people staying home is because people with chronic conditions have a weaker respiratory or a weaker immune system. And one of the hallmark things in a lot of COVID-19 patients is this idea of what's called a cytokine storm. Now, these cytokines are, it's a pretty loose definition. It's cells that can proteins that can affect cell signaling. So there are anti-inflammatory ones. There are things like interleukins. There are tumor necrosis factor, which is a thing that can help fight tumors, as you might expect. There's a whole list of there's a couple of different kinds: interferons, monokines, lymphokines kinds, interleukin, chemokines. All these different things. Like I said, it's a fairly broad group, but what happens is, for some reason, COVID-19, or the actual coronavirus itself, the novel coronavirus, causes this whole system to go crazy. And that causes a lot of different effects because, as mentioned, there's a lot of different kinds. So they have a lot of different effects. And that's why some people are reporting stomach problems, gastrointestinal problems. Some people are having sensory problems where smell and taste are going away. I was reading one article actually from a pulmonologist who recovered from COVID-19, who was saying that it might not even be necessarily a sensory neurological problem, but he noticed a kind of a biofilm developing in his mouth in the early stages that was kind of similar to thrush. And we know that thrush, which you can get from not rinsing properly after an inhaled steroid, that can affect your sense of taste. So maybe it's a blockade in that kind of sense. All of these things kind of kick in different ways. Sometimes there's inflammation in the lungs, which has been kind of a hallmark. We see a lot of people are still able to take breaths normally, but the oxygen level is low. And so we immediately start going into increasing oxygen levels and being aggressive with the ventilator, and then end up causing different kinds of damage. It's really complicated. As Russell's pointing out here, COVID-19 and COPD ignite similar cytokines. They certainly can. Again, cases are a little bit different. Now we're from what the data is evolving into now, we might kind of have two different pathways even for COVID-19. We're seeing people who are more traditional acute respiratory distress syndrome, and then we're also seeing people who are just hypoxic, and then they get tired, and then that leads to a lot of the problems, and maybe some of their issues are coming from ventilation. Joe mentions a couple of minutes ago, his guess for underrepresentation would be we're all being continuously medicated for lung conditions. So that's certainly a possibility. Again, we're looking at, is it the medications? Is it some of the immune response? What exactly is some of this stuff? One thing that I think hasn't been highlighted, but was kind of the first thing that came to my mind as soon as I saw that COPD was underrepresented, was what have we been telling you all to do? Stay at home, right? Bottom of the screen. I heard this from my one of my kids' principals. Sent out a robocall. They're going to be doing these updates, and had this idea of stay strong, stay safe, stay home. In Michigan, our isolation order is called the Stay Safe, Stay at Home order. You guys have all been staying home, and if you're staying home, maybe you're not getting sick, and that's why you're maybe a little bit underrepresented. A lot of folks with COPD take it very seriously. Once you have that diagnosis, and once you have that clarity, that you, especially those of you who have been unfortunate enough to have at least one exacerbation, you don't want to do that again. So you have this whole idea of you are taking the quarantine very, very seriously, much more so than maybe a younger person or somebody who isn't diagnosed and just thinks they're getting old or what have you. You all are taking it seriously. You all are, as Russell says, good at social distancing already, or the physical distancing. You're staying away from people anyway. You know how to prevent yourself from getting sick already. Everybody else is, you're just like, welcome to the club. This is how we roll now. But you guys are doing a great job. And honestly, those of you who have followed me for a while know I'm a fairly practical guy. I kind of like the idea of that. I think, there's the whole idea of the simplest answer is often the correct one. Maybe it's oversimplifying, I don't know, but it seems like a pretty straightforward explanation for what's going on. The stories of a lot of this stuff are well underwritten right now. We're learning new things literally every day. Again, this whole idea of, is it just the hypoxia? What role does that play? That's fairly new. We don't know what the eventual answer is going to be. We're seeing some of these interesting trends, these trend lines pop up, these patterns. It really caught my eye because I follow Dr. Halpin on Twitter. I know he's done a lot of great stuff in the COPD community, and I thought it was interesting. And I'm a little bit surprised that we haven't looked at the whole, just the fact that y'all are staying home as a factor. So if that's the answer, congratulations, kudos to you all out there. Keep doing what you're doing. Stay at home. I was talking with somebody yesterday and said, my best guess right now would be that once the common travel restriction or stay at home or isolation or whatever it is done, give yourself about an extra 2 weeks before you start resuming regular activity, because there's still going to be a lot of this stuff floating around. I'm seeing some reports now about this is probably going to be cyclical. I saw one study. I don't have a lot of, I didn't go back and vet it. I need to go back and look at, trying to be good with not touching my face. And boy, is it hard when you have an itch. So I'm going to grab one of my other props here. Wisconsin right now, they're anticipating one peak in about a week. And I know I've got some friends in Wisconsin. I know they're going through some rough times already, but the peak apparently is still coming up a little bit. But I also know that they're saying maybe another peak in August. So it's hard to say. We'll have to see what happens. So, just wanted to pull something up real quick there. I'll loop back around a little bit. Want to catch up on some of the comments here and say, let's see, that one was, so I think that's where we're at here. Want to say, let's see, that was, so I've got Gene saying hello to Gene. Appreciate you checking in from down in the great state of Tennessee. Gene is a fantastic respiratory therapist. And a home health advocate, doing a lot with nursing homes and all that kind of facility, durable medical equipment. So I'm sure he's busy right now at this time. James, it's a very good time for our patients to really sit back and take note on what might be causing their previous exacerbations, develop new routines and preparation when they start their day. Big thumbs up to the patients. Many are doing fantastic out in Oregon. So yeah, this is a great thing. You know, this is because your routines have likely been disrupted to some degree or another. This is a great time to see, okay, well, I'm getting up and I'm not coughing as much. So what's different about your morning? Are you getting up at a different time? Are you having more or less coffee? What is different about your daily routine that maybe is not causing an exacerbation? Because I have also seen some anecdotes on Twitter and elsewhere that a lot of what we would normally be seeing in internal medicine calls in maybe not so much clinics, but in ERs and in admissions and things like that are way down even more than they should be. And we know that a lot of people are trying to avoid the hospital right now because that's entirely appropriate, but we still should be. There are some places that are saying it's all COVID and nothing else. So it's really interesting, you know, keep it, and I know I can tell you on my end, you know, it's a different kind of stress at times. I know a lot of people have been talking about these changes in the routine and all that stuff. It can be stressful because you feel isolated, or you losing track of days and things like that. If you can get into a routine, whether it's the same routine or not, you know, that's kind of up to you. But it's interesting to see, as James says, what can we do to help use this time productively and see if there's something causing your exacerbation that you can lock down, and then, no pun intended, and then once the lockdown ends, figure out how you can adapt the positive change into your new daily ritual. It's interesting. It'd be a great thing to study, all that sort of thing. But the little prop could have been contaminated. Fortunately, I haven't really had anybody down here in the last 2 weeks other than my wife and a kid or two. So the risk of contamination is low. Yes, it absolutely could have been. Like I said, I'm trying to set a good example. It's driving me nuts again right now. I got another itch right here. I did wash my hands before I came down here, so I don't feel too bad about it. But thank you, Bonnie, for keeping it light for me. So what else we got going on in the world of COPD? Let's circle back around and see if we need any hellos here. We've got Roger checking in, Lori checking in, Roger from Ontario, Canada. So I appreciate people checking in. We've gone international now. I think I saw it, well, and Russell popped in there. We are global. COPD Navigator Global House Calls, everybody. So appreciate everybody spending some of your Wednesday with us. As I mentioned, often, we do at 4 o'clock on Wednesdays, we do more of a formalized show. I opted to keep it a little bit loose right now just because a lot of what we normally cover, we've been covering all week. We talk about news, COPD news of the week, and or 2 weeks. That has been largely at a standstill. As far as formal news and all that stuff goes, I'm looking at a couple of my common news sources right now, and this is the coronavirus crisis has had a lot of unusual effects that maybe we wouldn't have predicted. One of those things is that a lot of clinical trials and research studies and stuff have been paused to a certain degree or another because you can't get to the visits. Whether it's because the clinic is closed or the people have been reassigned or whatever it is, you can't get in to see the clinical trial. Publications have been paused a lot because, as I've mentioned a couple of times, big conferences are getting canceled or postponed. So the data is really slow to come out right now. This is maybe a little bit of a slow time anyway with ATS normally in a couple of weeks, which is, again, on hold right now. One thing that I'm seeing is, let's see, it's popped up a couple of times. I do want to point out that while we were talking earlier that it seems that folks with COPD are a little bit less likely to get coronavirus. If you do get it, you are more likely to get the severe stuff where you're going into the hospital, going on the ventilator, and having issues there. So don't get complacent. Be careful with this stuff. Again, continue doing what you're doing, keeping that physical distancing and all that kind of stuff. Keep going with all that, and because of that, it's working and it's going to stay working. So, what questions does anybody have for me? We'll scope back through here. Checking in with some friends in the RT community. Rose checking in from Kansas. Thank you, Rose. I appreciate everybody stopping by. And again, I've been throwing this out there a little bit more recently. If you would be so kind as to continue to like and share and subscribe on all the things between Facebook, YouTube, Twitter, trying to get the message out about COPD, trying to share these resources with everybody who can use them. Again, whether it's clinicians, whether it's folks living with COPD, whether it's caregivers. The novel coronavirus crisis will pass. COPD isn't going anywhere for a while. Especially since y'all are staying home and keeping yourselves healthy. We're going to need to continue to get awareness efforts going. We're going to need to continue to keep these fights going before, during, and after any crisis. So we need to make sure that we're getting all the information we can out there. I hope that this is of value to everybody enough to get that shared, because as the subscriber base grows, as the followers grow, it's easier for more people to find the stuff on Facebook, Twitter, and YouTube. So appreciate any efforts that you can do on that side of things. So and then, of course, want to answer as many questions as possible. So we're going to keep plugging away there. Got a couple people, looks like, watching on Twitter. This is really kind of an experiment. Haven't really done much with it. Need to apparently be careful with when I turn the camera on, because that's way down in the weird bits here. Also need to get used to looking at two different things here. I tried to get everything kind of set up in one thing, and I just don't have the right setup for that yet. So what are you going to do? Twitter is new. Those of you who were with us at the beginning of the program today saw, even with, I've been doing various live shows in different settings for a couple of years now, and each time there's, more often than not, there's a new set of challenges. So Russell comes out and asks, have you heard of the Halo device which measures inflammation in the lungs by breath? I do remember seeing something about that. Might have actually been you, Russell, checking in. One thing I also want to look at, Russell sent a great slide set yesterday for nutrition. I got to get looking at that here. So I want to pull up this Halo thing if I can. Every time I look at Halo, it brings up halotherapy. So, oh, this is the X Halo. I remember looking at this thing here. I believe it's the X Halo, which, oh, okay, now I get it. X Halo. Um, so we're looking at this device is looking at airway inflammation through exhaled breath temperature as a marker of inflammation in the intrathoracic airways. So what this device is doing, we've talked a couple of times about what role inflammation plays, whether it's in COVID-19, whether it's in COPD, what role, whether it's in the more chronic bronchitis stuff or the more emphysema stuff. We don't know fully yet, much like things are developing with coronavirus, things are still developing, not as fast as we would like with COPD and asthma, particularly COPD. One of the things that we're really interested in is inflammation, because again, kind of full circle, we want to better target our use of inhaled corticosteroids, because we do know that in some cases it can increase the risk of pneumonia. In some cases, it's not appropriate for somebody on COPD to be on a steroid. It is appropriate when those people have evidence of inflammation. Historically, we've kind of looked at that with a couple of different kinds of biomarkers. Sometimes it's a blood test. We're looking at the biggest thing is kind of eosinophil count, which is can be a marker of white blood cell white blood cells. Can be a surrogate for inflammation, all that sort of thing. In the asthma world, I know in our asthma clinic they use they look at exhaled. What do they look at? Exhaled nitric oxide. They have a device that can look for that, because that can be a measure of inflammation. This device purports that exhaled breath temperature, I'm assuming that the higher your inflammation, the hotter your breath would be. It says it's simple to use, very few consumables, immediate results, and possible to use at home. So that would be a fantastic tool if it becomes feasible. It looks like they're still doing some measurements. So I'm scrolling through their website right now, and it's saying that FeNO, the fraction of exhaled nitric oxide, has indeed been established as a non-invasive marker of airway inflammation, particularly in eosinophilic asthma. It has been demonstrated useful in monitoring asthma control and the anti-inflammatory effect of inhaled corticosteroids. Like I said, we use that in our very own asthma clinic. Recently, been looking at that, more affordable for use in physicians' offices, so there you go. However, the initial and maintenance costs of this portable device still limits its use. I do remember we were looking at maybe using it, maybe acquiring another device for the COPD side of things, and it wasn't feasible at the time. So we're still working on how we can adapt back and forth there. But this device is saying it's going to be cheaper, it's going to be more practical, and correlations have been found between the exhaled nitric oxide and exhaled breath temperature. EBT falls within a narrower band, but repeatability is quite high. So the initial indications seem pretty promising. They've got a couple of publications. Well, they've got a publication section. They don't currently have anything noted. So let's talk theory then. In theory, this would be a great tool. It seems to be, this is it would be in some ways literally taking the temperature of your COPD. If we can demonstrate and if we can establish this as a clinical tool, could certainly be very beneficial. We would imagine that we would see increases in inflammation as maybe an early warning sign for flare-ups, exacerbations, that sort of thing. We could probably use this as a helpful tool to figure out if corticosteroids are helping, if they're indicated, if people are taking them. We can do all kinds of measurements with that. So again, this would theoretically be a great tool that holds a lot of promise. I would like to see more information about how it works. Let me see if I can pull up. Sometimes this works, sometimes not. If I might be able to pull up a little inside the window here, I might be able to pull up a little inside the broadcast. I might be able to pull up the actual web page. Yeah, here we go. How about that? Wonders of technology. So this is the device. Does appear to be handheld. Let's see. I'm going to go back so I can read it a little bit easier. Let's see, 177 millimeters with the mouthpiece on, so that's not terribly big. It's got a small LED screen or LCD screen on it so that it can make that measurement. 3 to 4 minutes to complete one measurement cycle. That's a little bit of a bummer just from a technical standpoint, is because that just gives you downtime in the office. It would be ideal if we could bring that down to a minute. Of course, there are other things that can be done while you're watching somebody breathe into the machine. So it's certainly not a deal breaker. It's just maybe a little bit suboptimal. So we're definitely looking at, let's see, we got a mouthpiece on there. So yeah, again, I mean, if we can see a little bit more practical establishment of this device, I think it could work really well. So, yeah. So keep your eye on exhalo and exhale breath temperature. So what else we got, folks? That was a good one. Thank you, Russell, for bringing that to the attention of the crowd. Appreciate you checking in there. Let's see. What else we got going on here? It is hump day. We got anybody got those hump day blues? How is everyone's mental health doing these days? Again, that's one of those things we don't really talk about enough. I know, as we talked about earlier, any kind of chronic condition can lead to feelings of isolation and stuff like that, particularly when you have, everybody else is kind of in this thing, and when we have a lot of uncertainty right now, we have a lot of stuff going on. It's really easy to get frustrated, depressed. There's bad news on the news all the time. So let's check in real quick, socially. Let's see how things we can kind of reframe the idea of social distancing to mean being social from a distance, where we actually just have the physical separation, but we still keep the human connection. So let's keep that going. We want to talk a lot about social aspects in pulmonary rehab and things like that. This kind of stuff is critically important. So let's see. Do a little dance, make a little noise. So what else we got? We got yeah, this is your time, folks. I am here for you. So we've got all kinds of stuff that we can talk about. We've got inhalers. I got a little bit more organization today, so I actually know where stuff is. We got inhalers. We've got spacers. We've got oscillatory PEP. We've got a pulse ox. We've got spirometry. We've got one of my favorite little gizmos here, the in-check dial, so that we can, of course, this is more of a demonstration than anything else, but we can make sure that people are using the appropriate inspiratory force or inspiratory flow when they are using their dry powder inhalers. So what else we got? How's the weather? We had some interesting weather last night. Pea-size hail here in Kalamazoo. Some other areas were reporting even bigger hailstones. I saw probably a good palm-size one earlier in my Facebook feed from a little bit north of here. Fortunately, it doesn't look like we had any damage or anything like that, but we had our pretty good first spring thunderstorm last night, so that was entertaining. While we're waiting on some more questions, we will go ahead and circle through, see if we've got any other COPD news popping out here. Any new... let's see. Otherwise, maybe we'll just call it early. Go out for a bite to eat. Well, I guess we can't go out, can we? Go upstairs for a bite to eat. Let's see. Yeah, we've got all these news therapies, or all these news reports have been discussed over the last week. I guess that's the downside to doing a daily show in the middle of kind of a lull in the news cycle, at least the healthcare news cycle. Oh, speaking of healthcare news, this is Public Health Week, International Public Health Week. As many of you may know, I have a master's degree in public health, which makes me kind of a public health person. I always hesitate to call myself a public health professional because I'm not actually working in a explicitly public health role. I mean, I would argue that COPD is probably the biggest unknown slash underreported public health issue of our time, but John, yes, order in, get something good. Actually did that not long ago. I know that we've got, there are so many people that are affected by this. Restaurants are struggling right now. Delivery folks are struggling right now. I was reading a rather unfortunate report that said that possibly up to a third of restaurants might not reopen after this whole isolation thing. So let's see. One day ago, we had a report of maybe a new biomarker here. Serum beta-2 microglobulin is associated with mortality in hospitalized patients with acute exacerbation of COPD. So this came out, well, this was published a day ago, literally published a day ago. So breaking news. So they found this beta-2 microglobulin, which I had not previously heard of. And they did find that if you had a higher level of it, you were at higher risk of dying from your COPD exacerbation once you were in the hospital. So that could be interesting for a couple of reasons. First off, we'd have to do a little bit more research into what causes elevated levels of beta-2 microglobulin, because that might be an indicator of what's causing the COPD exacerbation. Or we might get to a point where we can see if you have an elevated level of it earlier on. We can do some kind of testing to make sure you don't get to the point where you're admitted. It's always good to have those discussions early on about expectations and things like that. So that could be a potential benefit. Could just be a predictor. Difficult to say at this very early stage, but anytime we can get some kind of new biomarker, could be interesting news. Russell asks, are there any new drugs in the pipeline, not repurposed, but brand new? Actually, yes. We did talk about one, that might have been a couple of weeks ago now, called, I'm going to see if I can find a good web page for it so I can bring that up, ensifenitrin. Let's see. So this is a medication. This is so if this was a class, I would ask everybody to raise their hand if you'd ever heard of roflumilast, which goes by the brand name Daliresp. I know a lot of folks are on roflumilast these days. That is a fairly new type of medication. It is a non-steroid anti-inflammatory called a phosphodiesterase 4 inhibitor. It works to stop a particular thing. Works to suppress airway inflammation. So there is this proposed drug called ensifenitrin. I don't know how to pronounce it. It's an E word. RPL 554. That's the code name for it, apparently. It is considered not only a phosphodiesterase 4 inhibitor, but also a phosphodiesterase 3 inhibitor. Now, phosphodiesterase 3 apparently helps relax some of the smooth muscle, so it's a bronchodilator. So we'd have that kind of combined bronchodilator effect with the anti-inflammatory effect, not even just in one medication, but actually one molecule. So it can be in and of itself. It is under, let's see, this was published in October of 2019 under clinical development for the treatment of asthma and COPD and potentially cystic fibrosis. So now I believe what we were last talking about was a couple of weeks ago. They had an MDI version, an inhaler version, or MISTI inhaler version of the drug in a clinical trial. So let's see. We saw one study that came out earlier this year, well, in January. That article was published in January, so late 2019, early 2020, that in combination with tiotropium, better known perhaps as Spiriva, seemed to work quite well. That was published, like I said, at the end, right about the turn of the year. And let's see. So this article from February tells us that in and of itself, let's see, just by itself, a dose-ranging study of the inhaled dual PDE3 and 4 inhibitor in COPD. First results published in 2018, further positive analysis in 2019. First in class inhaled dual inhibitor of enzymes. So, yeah, that was nebulized. And then, let's see, ensifentrine MDI. So we might actually have, yeah, here we go. So we've got a new trial. Did that trial just start? Yeah, okay, so this was a phase 2 trial of 5 dosage strengths of the MDI formulation. Based on the first part of the trial, plans to go ahead with the second. So, however, due to the COVID-19 pandemic, initiation of that portion of the trial will be delayed until further notice. So, what we've got is we've got a potential nebulizer version of this medication that's been studied for a couple of years, and then we're a little bit earlier in the pipeline for an MDI version. Now, when we're talking about why it's important when we're talking about nebulizers and MDIs and all that stuff, I am a firm believer in using the right tool in the right person. Some people do really well with an inhaler like this. Some people can't do the coordination and the pressing and all that kind of stuff, and they need the powder. Some people do really well with a powder inhaler. Others can't draw in hard enough. I talked earlier about using the in-check dial to do the measurement of inspiratory flow. When you can't operate the inhaler properly in either form, then we go to the inhaler or to the nebulizer. And some people just prefer the nebulizer anyway. Some people don't like to fuss around with it and don't mind that maybe it takes 5 minutes instead of 1 minute or something like that. So it's good to have as many different tools and as many different formats as we possibly can. John mentions the Reliance study is about to start to compare roflumilast to azithromycin to see which one helps the most. Interesting. I'll be interested to see how that works out too. You know, azithromycin is, of course, in the news a lot lately as a potential candidate with another med to fight against COVID with periodic results, anecdotal results. We're still waiting on some actual objective trials to see if that's really effective. But we do see a lot of times people are using azithromycin as a maintenance therapy for COPD because it's most commonly known as an antibiotic, but it does also have some anti-inflammatory characteristics too, kind of a secondary effect. Let me see if I'm going to, John probably knows all this stuff at the top of his head, but I'm going to see Reliance study for COPD. I just want to see if I can get a little bit more information about dosing and all that kind of stuff. So we've got this study coming up from PCORI, the Patient-Centered Outcomes Research Institute. So we're looking at, let's see if we've got, so we don't really have a lot of dosing or anything like that. Oh, we've got some registration information. So let's see if we can get a little bit more information about exactly what the head-to-head design is here. So we've got randomized 1-to-1 to receive either a prescription for roflumilast or a prescription for azithromycin. So we're looking straight up head-to-head about whether roflumilast or this antibiotic is good to prevent COPD exacerbations. Why does this matter? Well, roflumilast can be a great drug, but again, we've got side effects. We've got usually gastrointestinal side effects that a lot of people can't tolerate. Azithromycin has been around for a long time and again is pretty solid as an antibiotic, but can have some cardiac effects, lengthening out some of the cardiac intervals there, can also have some hearing effects. So again, much like using the inhaled steroids, we've got to go risk benefit on a lot of this stuff. And we want to make sure that we have a good idea of whether one of these is a higher risk for a higher benefit, like doubling down at the casino or something like that, or whether they're about equal. So, again, it's whatever side effects you can tolerate or whichever risk profile seems a little bit more appropriate for you, or whether, maybe we don't want to use either one of these. So John mentions using, which one are you using daily, John? Roflumilast, I'm thinking. Usually, well, there's two main strategies with azithromycin. The one we commonly use around here is taking it 3 times a week, but you can use a little bit lower dose daily, or I think, yeah, daily 5 times a week, something like that. I don't know if there's, I personally don't recall off the top of my head if there's strong evidence for one cycle or the other. Most of the research I have seen personally does the 3 times a week dosing. Please note now, doctors are sometimes advising half doses to begin with to help with nausea for roflumilast. So that makes a lot of sense too. Sometimes meds, and again, this is one that I actually have personal experience with because it was so John is doing the azithro daily, lower dose, but every day. So thank you for clarifying that, John. I've been personally on a medication where if I started at the actual dose when I jumped right into it, I felt terrible and then stopped taking that medication because it felt terrible. What's the point of taking a med if you're just going to feel worse on it? But if you can kind of titrate yourself up, like John is saying, with taking a half dose for a couple of weeks until your system kind of gets used to it, and then seeing if you can go up again, take that next step, and tolerate it, after you've built up a tolerance maybe, that can be very helpful. Sometimes you might even get benefit at the lower dose, and that might be an off-label indication or something like that, but maybe it works for you, and so maybe that's something that you can work out with your clinician. So it'll be interesting to see where some of these studies go. I would be really interested to see. The nice thing about this study is that I guess perhaps maybe not nice as compared to for a randomized controlled kind of thing, because there's no placebo, you're actually getting something. You'll either be getting 500 micrograms of Dalaresp every day, or you'll be getting 250 of Zithro every day, or 500 milligrams 3 times a week. So Roger reports in that he's doing erythromycin 250 milligrams 3 times a week. Erythromycin and azithromycin are in the same class. They're called macrolide antibiotics. They do have similar effects. Most meds in the same class have similar effects. Sometimes an individual's biochemistry works a little bit differently, and so you might have some adjustments there, but I'm actually not 100% sure why the focus is always on azithromycin. Haven't really dove too deeply into that, but erythromycin is certainly an appropriate alternative for that. So I'm glad to hear that there's not many side effects to that. I've also seen rash here and there and that sort of thing, but like I said before, at the end of the day, the best thing is to figure out what options we have so that we can make the most informed decisions we can for these medications. So be on the lookout for this Reliance study coming up. I will make sure I'll be working with John and keeping an eye out to make sure that when this actually does go into recruitment, we'll pass along some information about how to get into this study again. Kind of on hold right now with this COVID-19 situation, but looking at potentially getting it done by February of 2023. And then it'll probably be, so we will actually probably have some answers 2024 probably. So thanks, John, for pointing that out. We'll go through one last run through of any particular potential questions anybody might have. Otherwise, we're going to go ahead and start wrapping some things up today. Again, I appreciate everybody coming by on Wednesday. Happy hump day to everybody out there. Thank you for spending, let's see, here it is late afternoon, early evening. We'll have more in the afternoon. Let's see, Russell, that's a lot of math on the other side of the world there. So I want to say there's a 7-hour difference somehow, one way or another. So it's either really early or really late there. I want to say, are you 7 hours behind maybe? Am I going to join you at the 2021 Chicago Marathon? That seems unlikely. I probably should. You know, Russell has been a tremendous inspiration for a lot of folks in the community. One of the reasons I started getting my health together a few years back also, but I have never really been much of a runner. I can do the 5K, I can even do a 10K here and there, but I honestly, I don't know that I have a marathon in me. It's an interesting idea. I'll tell you what, I will promise to keep it in the back of my mind, if nothing else. But one of these days, that was actually another one of the events that got canceled this year was Kalamazoo Marathon. I know it's not quite as sexy or dramatic as Boston or New York or Chicago, but love to get. You know what I would do. I would travel to Chicago just to say hello and get a selfie or something like that. I might run a mile with you or something like that, but or excuse me, a kilometer. So I will keep that posted. I'm going to put that on the calendar right now because I've been looking forward to meeting Russell for a very long time, and I would be really excited for the opportunity to actually make that happen. So 16 hours ahead, according to John. So, boy, let's see. That would make it, let's see, it's 5 o'clock here plus 16 hours. So 9 in the morning, if I'm doing that right. Well, no, that's 7 in the morning. So that'd be, wow, that's a lot of math. 16 plus, anyway, it's a long time on the opposite side of the world right now, but definitely deal. Okay, excellent. We will get together in 2021 in Chicago. I'll buy you some oxygen. Drinks are on me, my friend. So appreciate everybody stopping by today. As I said, appreciate everybody taking some time out of your Wednesday. Again, keep up the good work. Make sure that you are continuing to stay safe, stay home, stay strong, stay uninfected. Make sure that you're continuing to keep the COPD community underrepresented in the COVID-19 diagnosis group, all those comorbidities. So 7 a.m. Thursday. So hey, I got it right. I got it more or less right. It is 7 a.m. there. Happy Thursday to you, Russell. Happy Wednesday to everybody else on this side of the international date line. We will see you again when it is Thursday here, and hopefully maybe Russell will spend some of his Friday morning with us. Until then, take care of yourselves, take care of each other, keep breathing easy, and I will see you all tomorrow. Take care, everybody.